Hey, good morning.
Oh, sorry, there I am.
Oh, I
Hey,
should say good afternoon
good
now.
afternoon. Good afternoon.
I apologize for my lateness. My computer, for some reason, has decided it wants to update, and it is not allowing me to log on. So I'm on my phone right now.
Okay.
Crystal, are you there?
Yes, ma'am, I am here. That's usually how computers do us, isn't it?
I'll tell you, with you to be, and I can't figure out how to do it on my phone. To be a co-presenter, I mean a presenter.
Co-host.
Co-host, if I can find out how to do it on my phone. And then I think I can switch because I think it'll let me log in. I just couldn't actually record people in.
Okay. Yeah, it's recording now, so we're good there.
Yeah, I just need you to be the co-host. And why isn't it not doing this? Of course. At least we have 5 people waiting to get in.
If I could.
Hmm. I think you got it, Dr. Brantmore. May have lost her. Let me see.
Yeah, maybe so. I see you muted, and I was wondering if I could make a request, but I can't see that prompt on the screen here.
Okay, let's see here.
Can you hear me now?
Oh, there she is. I was just fixing to text you. I was like, oh, I think we lost her.
Yeah, my computer's just down. Okay, so I'm gonna come on. Let me see. I'm just gonna introduce you, but yeah, it's gonna be hard for me to let people in. But Crystal, as long as you have to do that, I'm just gonna hold my phone and do this.
Okay, yes. So I'll go ahead and admit everyone now. So.
All right, sounds good.
They are joining currently.
Good morning, everyone. We're just making sure people that are in the waiting room have the opportunity to get logged in here. So we'll be getting started in just another minute here. All right, well, for those of you who don't know me, my name is Dr. Kenesha Bryant Moore. I'm a professor at the University of Arkansas Sciences in the College of Public Health. And this is our monthly virtual Faith Network Lunch and Learn. So feel free to get your lunch and enjoy the conversation we're going to have today. As usual, you try to log on and there's technical difficulties. And so if you see that I'm shaking a little bit, it's because I'm holding my phone because my computer decided to update this morning. I guess I hadn't been in the office because I was on vacation last week. So we're going to go ahead and I want to introduce our speaker for today. We have Kyle Jones from the Arkansas Hospice, and they are a partner of ours here at UAMS. And whenever we have the opportunity to highlight the work that's going on in the community, we want to do that, have that opportunity. So he's here to share some information specifically around African Americans in hospice, which is really important in regards to people really knowing what resources are available, knowing what not only what is available, but what they are, and really understanding that. And so while I'm trying to maneuver everything, Crystal Jones, who is our program manager for the Faith Network, will have my back here as we get situated. But I'm going to hand it over to Cal Jones now for the presentation, and then we'll take some questions and answers at the end of the presentation. But if you have anything that you don't want to forget or any burning questions, feel free to go ahead and put them in the chat, and we will get to them at the end of the presentation. So thank you so much for being here today.
Well, thank you, Dr. Bryant Moore, as well as Ms. Jones, and all of you who are in attendance on today. I appreciate the opportunity to share with you all some information regarding our current minority outreach initiative centered around hospice care as well as palliative care, and providing information for individuals in hopes that we can dispel some of the myths and overcome the significant disparities in regards to hospice care, end-of-life care in minority communities, as well as throughout the state, along with the nation. Our initiative that we are currently engaged in is referred to as Faith, Hospice, and Love. And as you can see noted there in the highlighted words, we are trying or striving to give hope in hospice care. And so oftentimes we realize that many individuals perceive hospice care as something that requires them to give up hope. And we want to make sure that we dispel that myth and to also be able to help people understand more specifically what hospice care is and how indeed it is important for us to be informed and aware of this opportunity in regards to our loved ones. If you would, I would like to just take you through all through this presentation. And again, as has been mentioned, we can have a time for questions and as well as the discussion here once we make it through our slides. Just a quick introduction of myself. I'm Kyle Jones. I do minority outreach as well as DEI work for Arkansas Hospice Incorporated. And all of this information that I'm sharing with you all, it can be found at our website at www.faithhospicelove.org. As far as Arkansas Hospice, our mission is to enhance the quality of life of those facing serious illness and loss by surrounding them with love and embracing them with the best in physical, emotional, and spiritual care. Our vision is to be the leader in hospice and palliative care through education, opportunities like today, innovation and transformation of the patient, family, and community experience. Our values are summarized in this acronym. We value life, love, and compassion for those we serve, integrity and respect for all interactions and relationships, faithfulness and stewardship of our time, talents, and resources, and excellence and uncompromising quality of care and the service we provide. I'd like to start this with a quote from Duke Divinity School Professor Richard Payne. You see it on your screen at this time. And the reality is that African Americans and other minorities are at a greater risk of not dying well. And now for many, this may seem almost like an oxymoron to think, how can you quote unquote die well? Well, for those who have experienced the reality of being a caregiver or having someone, a loved one who has been in the process of transition, we realize from those experiences that there are opportunities for us to be of greater service and to make this process as comfortable as possible. Historically, many of you may have experience or may have even heard stories in the past, such as myself, of my grandmother who took care of her mother in her home when she was transitioning without the benefit of anything such as hospice care. The stories that they tell and the process and how difficult it was and how it was taxing, particularly on the family in that time, are stories that still live with me, stories that have been passed down from my grandmother, who is gone on now, to my mother and to me. So these are things that I still, remember in in regards to those sharing of the stories. And I think many can identify with those stories in regards to similar situations where someone who was a loved one or who did not have anyone who could particularly take care of them. They didn't have the capability to be admitted in certain places. They had a transition that was very difficult and oftentimes very painful. And so dying well is something that we can do. But in order for us to be able to do that, we have to be willing to deal with the reality of death. Particularly though, just to help to understand this quote a little more with the nuts and bolts and some demographic information, as far as usage trends nationally, usage rates of end-of-life care for African Americans lag greatly behind that of their Caucasian counterparts. A particular example that we see using national Medicare statistics is that 50.7% of Medicare recipients utilize hospice care overall. So that's half of the individuals who use Medicare actually use end-of-life care or hospice care. But of that 50%, 82% of those individuals are Caucasian and only 8.2% are African American. And so we can see that the disparities are significantly different in regards to the usage rates. And so African Americans and other minorities in particular are at risk of not dying well due to the fact that they do not take advantage of these various resources, in particular around end-of-life care, hospice care, palliative care. But we also realize that this is a historical issue. And so whether we are talking about hospice care, end-of-life care in particular, or whether we're talking about medical care overall, we see that there are disparities, but those disparities are there not out of the sky or out of the clear blue sky or the air, but they are realities of history. And so an Institute of Medicine study helps us to better understand why these things take place. And a few highlights that we find in this information is that one, race alone accounts for disparate rates of medical treatment. African Americans are dying from treatable and preventable illness with more frequency than other ethnic groups, show higher rates of disease and more likely to die again from those diseases, as well as there are countless examples of African American patients experiencing discrimination and medical disparities in regards to their care. Oftentimes, we like to attribute these to various different factors. Some of those things mentioned are the reality that we are just 3 generations from slavery. Many still remember segregation, Jim Crow, and violence against them. Naturally, there's a deep distrust of government and the healthcare system. I think we've probably seen that more poignantly here in recent times after this study was completed due to the realities of COVID and dealing with the vaccine and all of the different talk that you hear and experience, whether you go to your secure news source of Facebook or whether it was just in the beauty shop or the barber shop. We see many different conversations and a natural distrust taking place in regards to government and healthcare in general. Encapsulating this, though, previously was data from a 2003 study. While this is dated, I think it still is a poignant fact that just around 50% of African Americans believed at the time that AIDS was a plot to exterminate Blacks. Now, I know this may seem mind-blowing to those who are more particularly immersed and educated about the spread of disease, in particular HIV/AIDS. But you see in parentheses, these things, these ideas do not, again, come out of a thin air. We realize that if I just say 2 words, it trigger often many memories for minority communities, and that 2 words are simply the Tuskegee experiment. So many people have thoughts, ideas, and memory around what took place. And so there are inherent, naturally developed, a natural distrust. And so that accounts on some level for the disparity. Regarding healthcare, specifically, especially at the end of life, it is little wonder that many worry that hospice is just another way to hasten death. And so we want to combat that myth and help, again, to dispel some of those disparities. We talked previously about African Americans experiencing a significant amount of medical discrimination. And so one example that I like to bring up, while oftentimes we talk about the reality of socioeconomic status and various things that may contribute to this reality, I do like to use an anecdote in regards to the notion that necessarily socioeconomic background doesn't necessarily determine the reality of whether a person will be discriminated against. If you have the opportunity to view the documentary presentations of 2 very notable public wealthy figures, probably the greatest tennis athlete ever, Serena Williams, as well as a very popular artist, Beyonce, Knowles Carter. If you look at their documentaries in their history in the regards to their sharing their stories around childbirth in particular, you will see that both of these women experience some level of medical discrimination despite their status, despite their wealth and their notoriety. And so again, we realize that race alone oftentimes accounts for these things. I don't have time to go into the detail around those specific instances, but I know that there are individuals who have experienced discrimination around childbirth in particular, but that leads to a natural distrust of medicine, of end-of-life care, of the care of African Americans and other minorities in particular. And so we realize that there is a challenge before us, and we realize that these fears and concerns are warranted, through experience. But we believe that through education, we can overcome some of these significant disparities and help individuals better see or understand the benefits of hospice and palliative care. Understanding our care, just as a definition, Palliative care is a specialized care for people with serious illness and who are indeed experiencing um, a type of illness that requires more specialized or focused care. Our specific care focuses on relief from the symptoms, pain, and the stress of the diagnosis, particularly improving the quality of life for patient and family. Palliative care is provided by a team of doctors, nurses, and other specialists, as well as it's important to understand that it is appropriate and available at any age and at any stage of a serious illness. Hospice care, more specifically, is a program of palliative care and supportive services, and it focuses on care and not necessarily a cure, managing pain and physical symptoms, support and assistance with emotional, psychosocial, and spiritual needs, and ultimately improving the quality of life. And so that is very, very important for us in regards to understanding palliative and hospice care. Improving quality of life is a primary focal point of the type of services that we provide. While there are opportunities, particularly in palliative care, to continue to seek curative treatment, we want you to understand that ultimately improving quality of life is our main focus. So both strive to relieve suffering and improve quality of life, as I mentioned, by addressing symptom burden aggressively, attending to the spiritual, religious, and existential needs of our patients and our families, and ensuring the care is consistent with the preferences and the values of our patient, as well as their family. And I mentioned previously that palliative care is appropriate for patients who are still continuing to seek curative and life-prolonging interventions. But to help with the distinction, it's important to note that hospice care recognizes death as natural. It enables patients to live to the fullest, and care is provided almost anywhere, and it allows patients to be surrounded by loved ones. One thing I would like to make sure to emphasize is while we have individuals who have some trepidation around dealing with death, it's important for us to have more discussions around the reality of death. It is a natural process and part of life, and sometimes, particularly in certain segments, we believe that we have the false notion. I would even further interject that by having conversations about death, that we will bring death upon ourselves and our loved ones. And so it's important for us to note that death is a natural part of life. It is something that most of us will experience. If you are a person of faith, there is an alternative, but until that moment does take place, then we all at some point are going to experience a natural death. And so death is a natural part of life. And once we have the capability to accept this reality, it gives us a better opportunity to deal with those things that we need to in regards to preparing for end of life and end of life care. And so hospice care focuses on these things, but it is important for us to be able to get to a place where we can actually discuss it in order to make a dent in those disparities. So when can one receive hospice care? Particularly, you have to be certified as being terminally ill by a physician and having a prognosis of 6 months or less if disease runs its normal course. And I need to specifically reiterate in this portion that we oftentimes mistake a doctor's prognosis as the quote unquote final say. I've heard it mentioned this way: doctors practice medicine, and they specifically state that because they are giving their most educated opinion in regards to what is taking place in the human body, but they cannot make a determination about a specific day that you will pass or about specific symptoms you will experience. Each individual is different and each case is different, but what the physician does is make a determination based on the information in front of them to be able to ascertain and to best project what is possible. And so it is necessary to have a prognosis of 6 months or less if disease runs its normal course, but that doesn't necessarily mean that a person who is on hospice care will transition or will die within the 6-month time period. And for this to take place, it is important to note that family can make a request for evaluation. And also your personal or primary care physician can make a referral based on the symptoms that they are viewing. In this question, individuals wonder what is hospice, understanding what that is, its definition and terms. The next thing people want to know oftentimes is how is hospice paid for? It's important to note that Medicare, as we mentioned in our example earlier from the statistical data that we shared, pays for hospice care. Medicaid, often many private insurances will pay for hospice care, but obviously those are individual policies and plans, and you would need to refer to your individual policy and plan to see if hospice care is covered under your life insurance or under your health insurance benefits. VA benefits as well as private pay. There are also opportunities, particularly with Arkansas Hospice, which is a nonprofit organization, that there are instances where care is uncompensated. But our mission is to provide care for our patients and families, regardless of their ability to pay. But those are the primary ways that hospice care is paid for. And so most individuals have coverage for hospice care if they are recipients of any of these in particular services that you see on the screen listed before you. Also, understanding what hospice care provides is or provides for in particular are medications, medical supplies, as well as durable equipment. And those, all sorts of necessary information and medication and supplies are all available to be paid for via hospice care. And if you've been a caregiver in the past or experienced this on any particular level, then you realize how much goes into this process, and all those things are covered through hospice care. Also, on a more personal level, it provides a hospice care team that provides family support, social workers, chaplain, as well as grief support. One thing in particular that I want to mention is the benefit of respite care that allows individuals who are serving as primary caregivers the opportunity to continue to live. If anybody has experienced the responsibility and the role of being a caregiver, oftentimes we realize that it is very taxing on that individual as well. There have been instances where someone who is providing care as a caregiver, due to the stress and the burden, oftentimes they become ill themselves, dealing with various illnesses due to just the level of stress that they've experienced in becoming a caregiver. We also see that this is an issue for families in particular as they try to navigate the roles and responsibilities of trying to provide care for a loved one. Hospice care and a team of family support individuals, as well as social workers and the chaplains, will be able to assist families in those moments of need, as well as to provide an opportunity for them to continue to engage in their various pursuits, to be able to provide for their families. And so hospice care is an extra layer of support that will help individuals navigate the transition of their loved ones. And even beyond that transition, Arkansas Hospice in particular provides grief support 13 months after the transition of a loved one. And so it's about the patient as well as the family, particularly for Arkansas Hospice. And so those are some of the things that hospice care provides in a broad sense. Though these services benefit greatly individuals who engage them, there's still a significant amount of confusion around hospice care and, again, what it is. And so we want to manage those myths around hospice and end-of-life care in general. There are some particular impediments to information, and I've hinted to this throughout the presentation. One of the biggest issues is that nobody wants to talk about it. No one wants to talk about death in and of itself. Again, the idea that we have some sort of control, so to speak, over the moment that we die. While we can choose to live healthier lives, and we can be safe, and we can take precaution in most of the things we do, it is still impossible for us to avoid death. That doesn't mean that you shouldn't take care of yourself or you shouldn't be concerned about living a healthy life and doing the best that you can. But the reality is that at some point we are going to die. And so we have to let go of the notion of control that we have, that we think we can avoid death, in particular, not talk about it. But the reality is that it is a natural process. It is a part of life. As people of faith, we believe that there is something beyond death, but we have to deal with the reality of death. Another impediment to information is that the perception is that hospice speeds up death. And I'll admit, prior to my personal experience with hospice care and my engagement and involvement, I kind of believed in this notion as well. And there, I believe, in all honesty, there's a simple explanation for this belief. Something that just becomes a part of what we, the mythologies that we take on and believe, just based on some of the experiences and coincidences that we deal with. The reality is that oftentimes, more than not, oftentimes individuals who are brought on to hospice care are often brought very, very late. More often than not, we see individuals who are admitted to hospice care, and within hours or days, even they transition. And the reality is these individuals probably would have qualified for hospice care years ago or months ago, but because they are only referred at the very end of the process, it then appears that hospice is speeding up the death process, when the reality is this individual probably and their family would have benefited from care, hospice care or hospice services at an earlier point. And there, would have, within that opportunity, they would have been able to see that hospice care is administered almost again at any place, and it is on the terms of the patient and families. One of our specific initiatives is in your home and on your terms. You have the opportunity to be served at home. A majority of our patients are served in residences. There are some individuals who are cared for in facilities such as nursing homes or specific places in hospitals. There are a couple of residential sites that we have as well throughout the state. But more often than not, this care is provided at home. So hospice is not a place, but a service. And so it does not require hospitalization, though there are some instances where families, patients, and doctors determine that hospitalization would be best for all involved. And also another myth is that which I mentioned previously. Some people hear the prognosis of 6 months and believe that care is limited to 6 months. But the reality is, again, is that while doctors make the prognosis, it does not necessarily have a determining effect on the date of transition or what takes place after. And so we don't just wash our hands at Arkansas Hospice at 6 months and say, well, good luck. We hope you, do well after this. But once you become a patient of hospice care, then you're under our care until the moment of transition. Or in the rare case, but there are cases, or there have been cases, where an individual would, quote unquote, graduate from hospice. Their health and conditions would improve so vastly that they would no longer require the services of hospice or palliative care. But you are our patient until you are transitioned, or whether you are transitioned via death, or whether your condition improves so vastly that you no longer require those services. So it is not limited to 6 months. We will not leave the patient and family at the 6 month point. And so it's important for people to understand that reality as well. So just covering some of those myths and realities, again, hospice is a place that is a myth. The reality is that care is provided at home as well as local facilities. A myth that hospice means giving up, but the reality is that palliative care is congruent with treatment. When diagnosed incurable, then we will focus our efforts toward hospice care in particular. A myth is that it is only for cancer patients, but the reality is life-limiting illnesses cover pretty much a whole swath of conditions. And so cancer, stroke, heart, and kidney disease, multiple sclerosis, ALS, Parkinson's, as well as AIDS, along with dementia, and a whole host of other life-limiting illnesses would qualify individual for hospice. So it's not only for cancer patients. Another myth is that it's only for seniors, but as I've mentioned to you previously, at any age, at any stage, young or old, we provide a customized care. And so we want to make sure that deal with those myths so that people better understand the realities of hospice care and of palliative care. And that will allow them to be able to better access the care that we provide. So at this time, I would ask if there are any questions. I don't know, Crystal, if you would facilitate those, or if I see any in the chat at this time. Well, I see a comment here, but again, is a reality. Thank you for sharing that, Mr. Sullivan, in regards to those natural dispositions and disparities, just due to the history, that indeed it does make sense. But we believe that we're able to combat that history with education in regards to the way things stand at this point. So we put the information in the hands of individuals and to help them to better note what hospice care is and what it isn't, that they'll have the opportunity to make those choices and to be better equipped to care for their families and their loved ones. Because ultimately, that's what hospice care seeks to provide, a set of tools and a team of individuals who would be there to support you as you care for your loved one. We are not going to come in and kick out the family and say that there's somehow we will better care for your loved one who you loved your entire life. But our objective is to be there as a support for you, for your loved one, and to provide them with the best care possible. And no matter how many days they have left, that those days be the most enjoyable, that they be the most comforting as they make their transition and as this process takes place. I see another in the chat here. Or said it states that the VA has programs where they will gather together veterans and talk to them about as a group about living wills and end of life care, and that is a great resource. Thank you again, Steve, for sharing that. I think it's important, and this is kind of a more of a broad reality in regards to dealing with death. So many times, because we won't discuss it, we're unprepared on many levels. And that has to do with living wills, as well as other preparations, funeral arrangements, and things of that nature that we don't prepare for in advance. And what oftentimes that leads to is, for lack of a better term, family strife. We see over and over again, many of you may have experienced the reality, is that when we don't address these issues, in advance, when their discussions are not had amongst family, then we have instances where we have individuals who come together and have to essentially fight it out amongst themselves because no one knew exactly what grandma's wishes were. No one knows exactly where this was supposed to go or that was supposed to go. And so we're kind of left to sort it out on our own. And oftentimes that leads to strife. But one of the greatest things that we can do for our families as we consider the reality of death and transitioning is to make some preparations in advance so that our family will be relieved of the burden of trying to make these decisions on the fly in very emotional circumstances. And so if you in advance discuss this with your family, then they'll know that this is not necessarily going against your wishes, but that you're okay with it. And so in regards to end of life care, palliative care, hospice care, living wills, and funeral arrangements, it will behoove us to begin to have more conversations with our families about death and dying so that we can make preparations to relieve them of the stress and burden as much as possible of the reality of this transition. Are there any other questions on this afternoon? See, I've just seen one pop up here in the chat. In short, let me back up a bit. In short, patient interactions, how do you debunk false assumptions that and show the importance of hospice for overall care? I think in those short patient interactions, you want to kind of have your quote unquote elevator speech of facts to the best of your ability. Obviously, wherever you meet an individual will have some determination about their reaction to the word hospice. Sometimes I've known family members to share with their loved ones. They would describe the services, but not necessarily use the word hospice until they were able to accept or agree with the services. And then they let them know what it was. Now, while I don't necessarily, I can't necessarily make the determination for you or your family or dealing with those patients individually, but I think the services are more important for people to understand. We are still trying to fight to make hospice not sound like a quote unquote bad word. And so focusing on services is important. And I think if you really lean into the services that are provided. Most people are agreeable to understanding that this is something that they would want for themselves, something they would want for their loved ones. And so in those interactions, I would focus more so on the services, because sometimes the word or the connotation can lead to those false assumptions. And, it takes some time to be able to go through and navigate all the different questions that they have. Now, once you can get them to agree to those services using the word hospice care or the terminology, then they may be more willing to listen and to engage in a longer interaction around what hospice care is, and you can then help them to assuage some of those fears, and to debunk some of those false assumptions. I hope that I answered that well enough. Also, one question that was mentioned: what support services should the faith community provide community members as it relates to hospice care? I'm so glad that you asked this, Dr. Odell Johnson. One opportunity that specifically I want to mention is the opportunity to have this as a presentation, to have this information shared in your faith community. I'm available to present. You can email at the contact information that you see on the screen at this time. Text that phone number, or if you have your cell phone now, you can pull up on that QR code and scan it, and will lead you directly to our Faith Hospice and Love contact page, where you can submit information for your faith community. I would love the opportunity to share this with the faith communities via Zoom or in person. If you're meeting in person, we can schedule around the schedule of your regular faith meetings to be able to have the opportunity to come and share this information at your request. And so this in particular would be a resource that you can share in a broader space with those individuals. Right now, we are currently engaged in an outreach initiative that has been supported by funding from the Hillman Grant and the Arkansas Hospice Foundation, where we are using the opportunity as well as incentives to share this information with faith communities. We've had about 3 presentations currently. We're scheduled to do a few more in the coming weeks. And spaces are limited for the opportunity to receive those incentives. And so if you are interested in that opportunity, or your faith community is interested in that opportunity, I would encourage you to go ahead and hit that QR code, or send an email or a text message, and make a request for further information. And I will be getting back to you very shortly if that is something that you would like to engage in. And so I'll leave that information up as I continue to go. I see another question that is mentioned. Wow, this is from Mr. Sullivan. This is a difficult topic to address. And how do you take care of yourself? I thank you, Mr. Sullivan, for the concern. Prayer is a primary in my self-care, but also, I try to make sure that we carve out space and time to be able to take any kind of personal care. But in all honesty, this is a difficult topic to address, but I feel like it's very important, particularly for our various communities. And on some level, it's a part of a calling. So I don't necessarily feel overwhelmed by this reality, but I feel like that I'm doing my part to try to help people live the best lives possible. And so I want to serve people and to help people to indeed to live those best lives. And so I don't necessarily get too overwhelmed with the job. There may be some other things that come along that overwhelm me, but again, I'm thankful for the opportunity to be able to share this information in hopes that ultimately we can make a change in our communities and make a change greater in allowing African Americans, excuse me, in particular, and other minorities, in a broader level, to be able to live again their best lives. And so I'm encouraged by it and thankful again for the opportunity to share. And thank you all for all of the comments, and I'm glad to share my gratitude for the opportunity once again to be able to share. And so I just thank you all for the time. And I will turn things back over to the Faith Network, Dr. Bryant Moore and Mrs. Jones. Thank you.
Thank you so much. We did have someone ask if the slides were available. I do want to let everyone know that we are recording this session and we will be on the College of Public Health's website. Excuse me, but I didn't know if you were open to sharing the slides or if you just would prefer people just watch the video to see the presentation.
It would probably be best if they would watch the video. That'd be great with some explanation there in regards to each slide. So yes, that would be awesome if they would have the opportunity to go back and to review the presentation.
All right, and so we should have that hopefully posted in the next couple of weeks, so folks can look out for that on our Faith Network webpage that is located within the College of Public Health. I also just wanted to highlight our presentation for next month. So you can see the flyer. We will be sending it out via email as well. But just a reminder that we do hold our Faith Network virtual lunch and learns the second Wednesday of every month at noon. And we use the same link to make it easier. So even if you are looking for it and you know the date and time, we use the same link so you can access the lunch and learn every month. Mr. Jones, thanks you again so much for being a part of this. It was a wealth of information, and it's been a privilege for me too, even though I feel like I've been in and out for serving as part of the advisor for your programming. But it's been a great working with you.
Thank you. Same. Thank you for the opportunity.
Definitely. So I'm going to give everybody, I think, 7 minutes back. Woohoo! For your day, so you can finish up your lunch, and we'll see everyone next month.
Thank you. Bye.